Um, Hi, good afternoon, everyone, and thank you for joining us to another Dental Chat by Alluro. We started this back in COVID, and it's just been continue. When we get topics or products that we would like to share to our customers. We really appreciate the ones that can join us live, but we're going to record this, and then it's going to be on our learning center in our website. Today, we're going to talk about your workflow at your clinic, and specific of are you high volume. And if you don't have an assistant, or if your assistant is not there all the time that you're working, this can be a very good tool for your day to day. We have Oriana today join us from ReLeaf. ReLeaf is a system on high volume that it sits in your mouth, and it helps to attract those aerosols and fluids, to help you in that. Noriana has been in the industry for 25 years. She's a dental hygienist, and she's been, working as a clinician, and I think she still does. But now it's on the other side of the fence and working on the manufacturer part of it. She's the director of clinical and strategy accounts at ReLeaf. And obviously, she's also a member of the American Dental Hygienists Association. And I met her, a couple months ago in Chicago. And great little product, fantastic tool. It doesn't cost a lot more, and it's going to give you a lot more freedom onto it. But anyway, no more to say. Thank you for joining us, and please I'll pass it on to Noriana.
Thank you everyone for joining me. It's nighttime at where I'm at and your guys' lunchtime. So I really appreciate it. Again, my name is Noriana. I am a clinician. I still practice, and I am the director of clinical for ReLeaf. So we're just going to dive in today about why ReLeaf would be good for you. We're going to discuss aerosol. That's very important, ergonomics, and our workflow efficiency, because all those are the three pillars that directly impact clinician longevity, and patient safety. And so I always just state I do work for ReLeaf. I've been a user of the product since 2018, but I'm also a clinician. I still work clinically. I know the pinpoints and the troubles we have in our workflow as we're doing more and more within our appointment time. So the goal of this session is really talking about practical implementation. It's just not a therapy. We're going to dive in again, like to that aerosol management, which again is standard of care, ergonomics, and efficiency, because they are all really interconnected. So we're modern. We don't practice like we did so long ago. Innovation has really taken off in the space of dentistry, and COVID really accelerated our awareness. We've always had aerosols, and we're going to still always have aerosols. But teams are balancing that infection control, their productivity, and the ergonomics simultaneously. We need clinical systems. I know I love a system because it's going to help us reduce that physical and cognitive workload. And we see the science that supports that we are, out of all of the healthcare professions out there, we are the highest exposure to those biohazards, and they're coming from the aerosols. We're also showing that our postures and our static positions contribute heavily to the pain that we are reporting, and the disorders that we see with a lot of clinicians out there that have been practicing a long time. Because again, when I went to school, ergonomics were not taught. I didn't learn that until only really a few years ago. But that reality of every day is we're exposed to those aerosols. We produce the most aerosols in all of medical. which is crazy, but we do, right? We're seeing more patients than probably your average physician a day. And if you're like me, I'm using a Cavitron, a piezo, an air polisher, every single patient. We know that those aerosols aren't limited to just hygiene procedures, right? You know, the doctor is going to produce it with high-speed hand pieces. But when we look at what produces the most, it's definitely our ultrasonics, then our air polishing, then those high-speed hand pieces, then the air abrasions, and even our air water syringes, which we use a lot to dry a tooth, to blow that tissue back so we could see if we missed calculus. And all of that contains possibly a hazard, right? We don't know. We don't have anything in our systems, in our operatory, like a system that monitors our exposure. And we know that aerosols are suspended long after a patient leaves, right? And we can't always lean on our ventilation because sometimes we don't know the building. We don't know what's being ventilated and what's not. But here we really have a risk as clinicians to breathe that in because we know not all offices have certain levels of masks to keep us safe, right? We have to sometimes work with what we have in our environment. And there's nothing in our operatory currently that tells us we're in danger. Like nothing saying aerosols are in danger, turn on your HVE or evacuate the room. Hopefully, maybe one day we'll have some kind of system there. But currently we don't. And again, those aerosols are spreading. We go home covered in them. I did a little AI generated picture here because we've in the US, it's a big video of if saliva were red. And that kind of, because again, saliva, when we touch it, can be invisible. We don't really physically have it like a biofilm, right, that we can see. And so aerosols, if they were red, we would see them. We'd be covered in them. Again, they're invisible. So sometimes our mindset is a little harder to comprehend of why it is so important. And now, too, water lines, that bacteria that's living in the water lines, when we activate that Cavitron, that bacteria is just being aerosolized and more risk for us to breathe it in. And again, like I said, we're at risk for COPD, asthma, bronchitis, all those things that are an occupational hazard. So using our HVE is so crucial, so crucial. And again, it's evidence-based, right? We know that HVE is going to remove the majority of our aerosols in the air. I always share the story when I went to hygiene school so long ago, it wasn't something that it wasn't a standard of practice. I leaned on the Slovak because it was easy. I could hook it in the patient's mouth and leave it there, and versus holding that HVE was very difficult, especially in school when you're learning. But we know now too, pre-rinses help reduce that bacterial load, which helps reduce those aerosols. Rubber dams are great, but not all practices use them. And we can't all use them on patients sometimes too. The ventilation, right? Certain offices have those big units like we saw during COVID to help pull those aerosols. And we have a lot of extra oral suctioning also emerging since COVID, again, because that innovation started progressing a little bit. So again, HVE matters. It's one of the most impactful interventions available chairside to us. It's already built in every operatory. But positioning and consistency also really matters, right? You have to be holding it correctly. When I started first using a Cavitron, I would hold it way outside the mouth when I should have been right on top of the tooth, right where I was working. But again, I was trying to lean in and see. Aerosol reduction is a systematic approach too, right? And again, the studies show that when we use HVE, we can reduce up to 90% of aerosols in our operatory, which is amazing. This guy is not going to reduce our aerosols. So this is kind of my don't use it anytime you're producing aerosols. Again, it's CDC guidelines, all these um, governing bodies say we need to be using HVE when we're producing those aerosols. And again, HVE has progressed so far. I mean, the metal straws, then the white straws. We have now mirror suctions, which are great. There's ones that go on your finger too. But for me, I want to hold my mirror. So I prefer hands-free. Um, there's devices that hold it for you, which is great too, but you're constantly having to reposition it when you're working, which can sometimes be difficult again because we're trying to not disrupt that workflow. And traditional HVE causes a lot of fatigue, right? It's heavier. We're readjusting the patients, we're moving the patients, that added time. But it's great to see that innovation is still out there and it's going to continue to be out there just as we progress in dentistry, right? Think about it, now we have AI looking at our radiographs. Like, how cool is that? I love it. I lean into that. Um, but when we think about HVE and us holding it, because sometimes we don't always have an assistant, sometimes we are working alone. Currently, here in the US, we're very understaffed. So, you know, the team fatigue of trying to balance multiple operatories and be there for our teammates. Me holding an HVE suction all day, I am not the happiest camper if they don't have a relief in the office. You know, clinicians, we sacrifice our ergonomics sometimes to maintain that positioning, and that again affects our body. So simpler systems really improve the long-term compliance of it. Um, when you think about your office, what barrier does your team have with consistent HVE? It might just be staffing. It might be your assistant's already been working 40 years and she's had 2 shoulder surgeries. Finding a solution for her, right? You want her to stay there another 40 years. And two, when we're using all these aerosol producing, procedures, we're producing a lot of water, a lot of moisture, right? And that can affect our restorative qualities. And that's why we use HVE too, right? To keep that tooth dry while we're in those steps of placing that restorative composite. Because we know that even minimal contamination can really affect the bond with some material. Every material is different. And we don't want those margins to become leaky because we know then you can have postoperative sensitivity, failure, fractures, remakes. So moisture control is also really crucial for our vision as well. So again, it's just going to be an added benefit when we use HVE. And we're constantly fighting the tongue, the cheek. We have all these factors too, because every patient shows up very differently. Not all patients are created equal. Not all of them have, it would be nice if they had like zippers and we could open them up to work on them how we wanted to work on them to make us easier. But that's just not the reality of our day to day. And so hands-free suction is where I really see the benefit with, again, our work for our ergonomics and our aerosol control. And what's nice about systems that are hands-free is the placement is more controlled. So we're getting a consistent capture of those. Here, there is a Mr. Thirsty, there's an aerosol assist, and there's a ReLeaf. Those are just some of the options out there. I typically favor ReLeaf. I've been a user since 2018 when the company launched. Just because of how it fits in the patient's mouth, the comfortability. Some of the systems that have a bite block and retract the tongue out, you can only see half the mouth. And so you have to take it out, place it back in, and sometimes patients can't tolerate that. I really lean into the hands-free as again, my non-dominant isn't getting that strain and I'm not having to reposition. And patients really like it, depending on what system you use. I mean, if you use ReLeaf, they're really gonna love it. But again, just finding a tool in your toolbox for you as a clinician. And ergonomics, again, when I went to school so long ago, we didn't have saddle chairs. Um, Most of us did not even have loops, and the loops we wore were very heavy, so we didn't wear them a lot of the time. But now we know so much more because, again, we're evidence-based research that we can recognize these risk factors because studies have shown 60 to 90% of clinicians report pain, whether it's their shoulder, their neck, the back, the wrist, it's all affected. And the issue is not just one bad posture, it's a repetitive, workload. Even just tilting our head forward in a procedure can add multiple pounds on our spine, which is crazy. I did not really understand that concept. So when people tell me, oh, loops are too heavy now, especially with the loops that we have now, I said leaning in just adds all that pressure. I want to stay the same height. I don't want to shrink as I get older. So, and I think what the leaning that head posture, I think it was about 27 pounds was one of the research studies I read. That's a lot of weight. I don't even lift 27 pounds when I work out. So that's a heavy amount. And if you're doing that all day, it's not like our necks are getting stronger. It's bearing the weight. That strain is happening and we pinch down on a force that blood flow restricts. Again, what we know now, saddle chairs, just such a innovation again, where we're going in dentistry, which helps us that longevity. Because again, for us here in the States, we don't have many clinicians. We're in a shortage. So who we have, we want to be able to keep, and them not to have any issues with their body, so they come to work. So again, ergonomics is prevention. It's not a reaction. Those strains affect both, you know, doctors, assistants, hygienists, and with that, also that impact of the workflow efficiencies increase. Physical stress increases with that. So better evacuation systems really help us reduce unnecessary movement within the practice. Workflow is something I really appreciate now as a veteran clinician. It wasn't something that I really understood in the beginning of my career. Um, where this tray sat or what was in this drawer, because now I can see the efficiency. Especially in my practice, when we got an iTero scanner, we had to start scanning all our patients. It took me 20 minutes to really scan somebody at the beginning because, you're just learning. You get better with time, but that 20 minutes really cut into all of the other things I had to do within my appointment. And again, using systems and tools to help that workflow allows you to balance that time, right? We kind of negotiate with time sometime. Oh, if I use this, then I can do this later. But just really evaluating your workflow, right? If you're constantly having to reach or trip over a cord or bang your head on the light, your operatory's got to change. It's got to work for you, because that again, that grabbing something out of a drawer adds time, moving something around or even just getting bonked on the head. That's painful. You got to take a break, assess the situation, and then continue to treat your patient. So those small workflow improvements compound over time. That efficiency, and again, to reduce that cognitive load and stress, and the ergonomics and efficiencies all support one another. So I always say, use your tools. I always tell everybody my operatory is my toolbox, and I have tools for any type of patient or situation I'm in, and I use them. I don't think about it later, because if I thought about it later all day long, I would be the one late at night writing my notes. I would be, blasting 80s music on the way home just to decompress from a very stressful day. I love the 80s. It's my decompression movie music, but it's not something I want to have to do every night when I leave work. So when we talk about those workflow efficiency, again, treat your operatory like your toolbox. If tools are missing or poorly placed or used out of order, the job is going to take longer and cause more strain. So talking about that aerosol, the ergonomics, and the workflow, ReLeaf is there to help you with all of those things. So I love to share this picture. So this is Hari. He is who invented ReLeaf. He's a dental assistant. So when Hari first went into the workforce as a dental assistant, he worked in sedation dentistry, where sometimes they would pack gauze down the throat, or they would use systems like Isolite, Dry Shield, Mr. Thirsty, things like that, that block the airway, retract the tongue out, and he could practice four-handed dentistry and really be efficient with his time. Remember, those patients were sedated. It's easier to work on sedated patients. They're not telling you how they feel. They're not gagging. They're not trying to talk. So then after that, he moved into general practice. And boy, did Hari struggle. He struggled to hold an HVE. He struggled handing instruments at the same time. Um, Patient management. He really struggled with patient management. And this was early 2000s. And so he decided there's got to be something better out there. So he went and researched and looked, and really there was nothing because, again, COVID hadn't been brought to our attention. Innovation wasn't out there. So he tinkered around. He actually went to the hygienist and said, "How do you guys stay on time all the time?" We tend to be really good at that. And they again we're just like we hook the Slovak. We know we're really not supposed to, but we don't really have anything. We just use what we have and make it work. And so Hari tinkered around. The shape of the leaf is shaped like a triangle, and that's what Hari thought of. Like, what is already existing in this room that we use on patients that they would be comfortable using? And so that's how the ReLeaf got its shape like a leaf because triangle, and it rests in the buckle just like a triangle does. So Hari tinkered around. He taught himself CAD, and he wrote his own patents and had this dream and didn't know really how to get it to market. So his really good friend from high school helped raise money and investments and got to launch ReLeaf in 2018. So many years it was spent in development and design and, just some of the sketches I've seen at the beginning of just his drawings, just to where it is now is amazing. So again, he wanted to find a solution for the clinicians when we need an extra set of hands and don't have it. So it's going to assist with aerosol management, moisture, and it's really going to support us in our ergonomics. I'm going 25 years in dentistry. I have body aches. I've had hand surgery. I want to still practice clinically for many, many years. And ReLeaf has helped me to do that. And really, it's going to help the workflow. So, what we have found in research articles is when we use a hands-free suction, we save to 10 to 15 minutes in our appointment time. And that's because we're not picking up and putting down a suction. We're not adjusting the patient. We're not sucking up a tongue and then taking time to release the tongue, or a patient chokes on water and we have to sit them up. All those play in a factor of our patient management and time management. So that's what ReLeaf looks like when it's plugged into our HVE. And these are typically a picture of what our kits come like. Our starter kits is they have one long tubing, which plugs directly into the HVE, a sampling of both size leaves. So the leaves come in two different sizes. The green is what we call the standard and the mini. So I always show them comparatively. They're a good bit smaller. Some people think minis should only be for pediatrics. I specialize in perio, and I used to cut this guy to be this size until we started making this size because I had a lot of elderly patients that were just petite, and I had a lot of high anxiety patients that really couldn't tolerate much in their mouth. Um, so here's a video. We blew smoke in the mouth because aerosols are invisible. So how can we show you guys what aerosols look like? So smoke machine. So the relief is on, the smoke machine's still going, but those aerosols are being captured at the source of the mouth before it's exhaled, right? So now we reduced our risk of those aerosols, not just to us, but to everybody who's walking in that dental office. So you can see there how the relief rests in the buccal mucosa there. And then I kind of want to talk about the leaf. So that leaf is disposable. It's a one-time use. That leaf reduces 87% of aerosols when we did a study during COVID. That's a good amount of aerosols we're reducing for something that's sitting in there and we're not having to hold anything. So that leaf, all around the leaf part, there are these channels. There's 14 of them, and they're 1 by 5 millimeter openings. And then on one side of the leaf, we have a 4 millimeter, what we call the calculus port. But we all know calculus comes off in big chunks or sometimes flies out the mouth. So it's going to, depending on the size, be able to be sucked up into your HVE. But typically, sometimes calculus falls underneath the tongue. We're picking it up with a 2 by 2 or our pliers. So we're drawing all that air from multiple channels, which is great. That leaf can go on either side of the buccal. You can easily move it in and out, depending on what side of the mouth you're working on or how the patient's leaning towards you. So that total orifice of opening is over 70 millimeters on the adult, on that standard green, and then about 50 millimeters on the minis. We do get a lot of questions about the 8 bore millimeter opening, especially here in the States based off some of the research that was published many, many years ago. And that kind of 8 bore millimeter was shown because there wasn't any innovation at the time. All we had when a lot of those research papers came out was a white straw. And the valve on the opening is typically an 8 millimeter. But if we think about it, the extension of the hose inside the hose is not. And two, it all depends on what your compressor is going to run. There's such a multi-factor on how much aerosols are being, absorbed into our system is how many operatories are we running with all the valves on? Is this compressor new, old? Are the lines maintained? There's so many factors on how aerosols are going to be absorbed at what rate. So sometimes we get that question, well, you're not an 8 bore millimeter, but we're actually more. We're, 14 plus. So I get that question a lot. And again, that straw, I don't want to hold. I want my mirror in my hand. I want my indirect vision. I don't get an assistant. So this is a great solution for so many clinicians. And ReLeaf can be used, again, hygiene, an assistant, a doctor. If the doctor has to work alone and the patient can't tolerate some of the other, hands-free systems, ReLeaf's a great option. And again, it sits in the buccal like a triangle. So we're not triggering a gag reflex. Patients feel they can talk and just feel in control. With our nervous Nelly patients, it's very, very important. The leaf is latex and BPA free, so we don't have to worry about allergies or patients concerned with BPA. That's a big concern for some of our patients. So this next video I wanted to show you is ReLeaf not being used next to ReLeaf being used. And you can see that light illuminating. You can see that droplet and those aerosols coming out of the mouth, right? Again, it's invisible. We cannot see them normally. And then that other one where ReLeaf was being used and we're not seeing those aerosols go out. We're not seeing that splatter go out. We're seeing it captured at the source again, which is so crucial. So I always too like to walk everybody through. So here I have my relief tubing, and this is typically what comes in the kits. There is this adapter here, which has a little U-shaped clip. So that one end of the adapter plugs into your HVE. If your HVE, if it's never snug, sometimes you just need to replace your O-ring. And then this disconnects here. So we call this the short tube. I like to call this a macaroni piece. Some people like to call it a U-bend. We don't judge. You can call it whatever you want. So that is also removable if you need to remove it. And then in that U-shaped clip, I plug that in. So this is what it looks like before my patient, is seated in my room. Then I decide what leaf. Like I said, I favor the minis. Make sure that hole is facing out towards the tongue. And then I just have the patient open and I slide it in the buckle.
Sorry, Noriana. I think we have the share screen, so we can see you just in a
Oh, you
tiny
can't see
window.
me?
Yeah.
Okay. So I'll do that at the end. Thank
Yeah,
you,
we do it
because
in the
I
end. We
want
do it
to
in the
share.
end.
Yeah,
Mm.
yeah. So really, relief is going to be a great option not to look like this at the end of the day. So let me stop sharing and I'll run that through again. Okay. So here's your HVE valve. I'm going to take this off. So you get this one long tube with this adapter and that C-shaped clip. You're going to plug that straight into your HVE. You're going to connect your short tube and your macaroni piece together, and you're going to rest that in the clip there. You're going to pick out your leaf. Again, that hole is going to be facing out. And then I just have the patient open and rest it in the buckle. So you can still talk. You can see the whole entire oral cavity. You can flip it from side to side, whichever your preference is. And then when you're done, you're going to just throw the leaf away. For sterilization, every office is going to do it a little different, and that's okay. So anything white and gray is autoclavable. In my operatory, I leave my long tube on because it's just like an extension of my HVE. So I wipe this down and I run my lines. I do scaling and root planings all day long. So I typically run my lines a little bit more just because of the amount of stuff that I'm getting out of patients' mouths. And then after each patient, I take off this short hose and U-bend and I run that through sterilization. So this is really lightweight, and you'll notice that when you work with it, which is great because it's not like, pulling the patient down. But when we put that in the ultrasonic bath, sometimes it likes to float. So then that solution doesn't get into that tubing. So I like to press it down a little bit and make sure that water fills up before I turn my ultrasonic cleaner on. You can also some people like to put a little brush through there. It is a little longer, so it takes, you have to kind of go back and forth. Um, this U-bend will sometimes just get really grody depending on your caseload. I use a lot of disclosing solution, so mine typically like to stain a little bit. You can get a brush in there from both sides, but it does get hung up a little bit on this U-bend from time to time. But just do the best you can to get it in there. And then sometimes I will, just depending again what my caseload is, I may have to run this through the ultrasonic bath twice sometimes. And then this would be bagged and sterilized in your autoclave. You can separate them or you can bag them together, whatever. Sometimes it just depends on the size of your bag. I don't recommend doing this with it, just because you want that, to I don't know, sterilize better. And then you can always run your long tubing through your autoclave as well. So some offices that I work with, they run it nightly through their autoclave. Some do it weekly, monthly. I would say personally, I've do mine every couple months, and I do not put this in the ultrasonic bath because Personally, what I have found is when you put it in there, depending on what the size is, and you take it out, you're flinging more of that solution everywhere, which then you're just cross-contaminating everything and you're getting covered in it. So I just ensure I run my lines again, wipe it down, and then I just coil it up and put it in a bag. So again, it's just an extension of your HVE line. So that's kind of at the discretion. Um, I did want to say two things that I've experienced and I get the most feedback with is some troubleshooting with sensitivity. Because it is a high volume, you are drawing more air, and if the patient has some root exposure and they're not numb, they may have some sensitivity. Move it to the other side if they're not sensitive and see if that alleviates that. Um, you can place a desensitizer on the tooth if it's just really localized. You can place fluoride if they're okay with it. Sometimes I'll put a little 2x2 and I will just roll it up and place it on the buccal just to act like a blanket to help them. So again, that just kind of depends on the patient. I have some patients that I'm just using the ReLeaf because I can't use an ultrasonic on them because of their sensitivity, but they have so much saliva. So I'm using it as a moisture control. And I'll just reduce the valve a little bit too, which will help with their sensitivity. Also, patients that are elderly, their buccal mucosa sometimes will be just a little bit more loose. And we've seen it get kind of sucked around these channels here. So what I do is I wet a 2x2 and I place it in the buccal first before I put the leaf, just to keep that tissue retracted back as I need. And then I just make sure I wet the gauze before I take it out because I have peeled some cheek off accidentally. We learn chairside. Um, but yeah, I would love to answer any questions or um, I was like, Rudy, did you have any questions for me?
Oh, okay. Hello. Sorry, it kind of cut off in our side. Hopefully, you guys didn't cut off. Is that all right? Yeah. Yes, I do have some questions. And if anybody has any questions, just put it on the chat and I'll read them for you guys. Thank you. That was really cool. First of all, what do you think it's, or from the feedback in the market, what's the biggest challenge to adoption into this? Sometimes when we talk to customers and they use it for the first time and they've been using different things or just a low volume one saliva eject, hooks in and this is kind of different for them. And they were like, well, I don't know, what on your experience working with other hygienists, what was the biggest challenge?
I think for some hygienists, they've always held that Slovak in their non-dominant hand, and kind of adjusting to be able to use their mirror again is a little like, oh, my hand is free. Oh, I'm not used to holding something. Sometimes the noise, right? HVE is just louder in general. So that can sometimes be a little of a deterrent. But don't let that be. Lean on that. What is the standard of care is to use HVE, and it's going to be noisy no matter what. So we just might have to
Mhm.
talk a little louder. Um, and
Okay.
some hygienists wear ear protection if it's just longevity of just that exposure to reduce any hearing issues, just like with the ultrasonic scalers. Yeah.
Yeah. And what about with the air polishers?
So I love it with my air polisher. So I've used air polishing for quite some time. One thing I think too is it's gonna that water that tends to pool, you're not having to worry about like readjusting and or giving the patient the suction to hold because most of the time we are disclosing the patient with systems like that, right? We're chasing that disclosing solution. So we're really staying focused. So that's a nice that ReLeaf is resting there to do all that work in the aerosols and the splatter in the water so you can continuously work. Um, I will say that I personally get a little bit more of water pooling because I use the minis. So again, this is going to just be based off patient size of the mouth.
Mm.
So the larger green size will extend more down that retromolar pad for that water pooling. Um, you can have your patients close. And I say that with a little like, always be cautious of backflow. We're running HVE, so less likely for backflow. Don't have the patients hold down on it for dear life. Usually, what I tell is I have patients just bite down and smile, and
Hmm.
that will draw a lot of that moisture that might have been pooling.
Okay.
With air polishing too, when you're working around the anteriors, that's when you're going to get more of that splatter. You're not getting an aerosol so much, you're getting more of the splatter. So sometimes just moving the leaf out a little bit, um, like this, will
Hmm.
help with that as well. Or two, if you have dual HVE, maybe that's when you pick up your straw just to work around your anteriors.
Okay, fair enough. And what about retractor? Was you use a retractor when you use a air polish app, but do you normally put a retractor with just a scaler or not really, just with that?
So personally, I don't use the retractor anymore. I did probably when I first started learning it, just because for the patient education, they can see all the disclosing solution backwards. You can use ReLeaf with a retractor, Optigate, or whatever brand you use. It fits in there just fine. For me, I just felt like the retractor would sometimes get in the way for me, so I don't use it anymore.
Okay. Okay, fair
But
enough. And you just said before that the small one, it's like where you kind of like to use. It's is it occasion like that will be you 80% of your uses. It's funny because we normally sell more of the green ones, while we sell
no,
little ones. The
I was
little
like,
oh, but that's the perception of like little ones are for kids, pediatric onto it. So
yeah, and the green ones have been around since 2018. We've only had the minis out for a few years, so some people don't know they're available. So that's why we kind of see that. And then too, patient demographic or clinician preference. Sometimes if you notice that the leaf is coming out, if you put the green leaf in and you notice you're always having to push the leaf back in,
mm,
that's typically means the leaf's too big. So
okay,
that's another kind of
okay,
troubleshooting we get. But
okay,
yeah, so just I like having both sizes in my operatory just because again, patients come in different sizes, but I favor the minis.
right, okay, fair enough. Lisa, do you have any questions? No. I think that they're all the questions that we have. I will just gonna suggest, like, if you are in the webinar right now and you haven't tried it, just put it on the chat that you would like to try, and we can give you a little trial pack for you to try. And if you already use, thank you. Yeah, that's good. We will wrap this up. I'm also gonna type the CPD point number there for the attendees, and we will send an EDM with a recording of these once it's a little bit edited and a few little deal there for the people who are already buying on the leaves, and then also if somebody wants to try it. But before we go, thank you for the ones who join us, and Norena, thank you so much. I know you were in the conference and leaving the booth. It's always hard. You left your team behind there, but we really enjoy it, and I think it's funny you talk to customers and they are thinking of the low volume devices that they are there, but when you picked it up saying that is a high volume, they're like, oh, hold on, what? And so on and so on. I also gonna say there is a little trick. If you high volume doesn't have on and off valve and you need to lift it up, you can just that C cap that you hook the longer, you can just put it underneath and kind of leave it on lift. You would know what I mean. So you keep it running the high volume onto it. And not further out, yeah, thank you for joining us and your support. I'll say goodbye to everybody, and I will just ask Norena to stay for like a little bit longer. But thank you everybody for joining us
Thank you,
for
everyone.
those